So the next session will be on parotid and submandibular swelling.
Thank you, sir.
It will be moderated by Dr. Vidhan Roy. And the faculties are Dr. Arunava Sengupta, Dr. Ruma Guo, and Dr. Devaruto Das.
So after the two heavy sessions of thyroid and oral cavity malignancy of the oral cavity, that is tongue. So this will be a relieving session for you, a bit lighter one. So this will, the section of the salivary glands in which you will be taught, I think you already know everything about the parotid and submandibular salivary gland. So this is in a nutshell, because it will never be given you as a long case. Mostly it will be given as a short case. If it is available on the day of the examination, and if you are giving a good viva, then you will might have some questions from this area of parotid and the submandibular gland. So our moderator is Dr. Vidhan Rai sir, and the faculties are myself, Dr. Rumadi. And Dr. Professor Arunava Sengupta is also one of the faculties. Sir probably will come within the next 5-10 minutes. So you will start without, because of Rajiv is standing there, and the clock is ticking. So without wasting the time, we'll start. So warm welcome to Yogesh ji, Dr. Yogesh Dabolkar.
He is the editorial chairman of Indian Journal of Otolaryngology and Head Neck Surgery. He is HOD at the D.Y. Patil Hospital, Navi Mumbai, and also he is the national observer for this program. You know that this program will be in 8 cities throughout the country. So he is our national program. Please give him a big round of applause.
Vidhan sir, please start.
So good morning everybody. So this is the session of salivary gland diseases. We have 2 case capsules. First one is a parotid swelling. As you can see the parotid swelling here. Now the presentation, 45-year-old female presented with chief complaint of swelling in front and below the left ear lobule since last 4 years. The patient was asymptomatic 4 years back. Later she developed swelling in front of and below the left ear lobe. When first noticed, it was peanut sized and has gradually increased to its current size. There was no associated symptoms. So based on this above chief complaints and history of present illness, how will you examine the case after getting a detailed history? I mean, if we talk about a detailed history, that means we need to ask some relevant leading questions to the patient. What could be those relevant questions in this particular case, and how you will examine a case of parotid swelling? Any response from your side?
Last bench থেকে শুরু কর. Last bench, you.
First of all, this is already told that it is a parotid swelling. Now my question to you is, why you are calling it as a parotid swelling? Define what is the parotid region, I mean.
Ma'am, first I will check for, general examination I will do.
Pardon?
First I will go for general examination of the patient.
So no, you didn't
Not
get
that-
the
No,
question.
anatomically what I am trying to ask, sorry, anatomically what is the area of, why will you call it? So it is a swelling on the left side of the face. So why will you call it as a parotid swelling? Rapidly, next. So what is the anatomical position of the parotid? That is the simple thing. So superior border, it is formed by the zygomatic arch. Anteriorly, it is bounded by the masseter muscle. and posteriorly by the anterior border of the sternocleidomastoid muscle, and inferiorly, and also the external auditory canal, and inferiorly by the inferior border of the mandible. So this is the region of the parotid, and there is a swelling over there. So we are calling it as a parotid swelling. Okay. So just to make it clear that we are not going to understand or know any new thing, only the recapitulation of the things which we have learned over the months. So that is the parotid swelling. So what is the history? Now the sir has already told the swelling is in the left side of the parotid region for last 4 years, very insidious in progression, and it is a size of 8 by 7 centimeter approximately. Now what is the history of present illness? What are the important points? This is the chief complaint. There was no other complaint for the patient, and what are the main points he will ask in the history of present illness? Number 1, pain over the swelling. What does it mean? If the patient has pain over the swelling, patient will complain. You are not examining. So what does it mean? Simple. So yes, it is acute parotitis or inflammation. So you will have to exclude that. Variation in size while chewing food. What does it mean? Or there will be increase in the size of the salivary gland. What does it mean? Pardon? Lithiasis. There might be some obstruction in the Stenson's duct. Now tell me what is the opening, where is the opening of this? Very fast. So where it arises from the anterior border and medially from the parotid gland, it overlies the masseter muscle, it pierces the buccinator muscle and opens in the oral cavity, just opposite the second molar tooth, maxillary tooth. Okay. So that is the region. So variation, if there is any type of obstruction in the Stenson's duct, there will be change in when you will chew food or have some sour food, there will be change in the size of the gland. Purulent discharge from the mouth. What does it mean? Again, examining the Stenson's duct. How will you examine? Although it is a history, but together we are not keeping any watershed line between inspection, palpation and all that. So how will you examine the Stenson's duct opening? Last bench, tatari bolo. Very good. You are putting, you are examining, Sir Ashwin. Sir Ashwin. Good morning. So you are examining it bi-digitally, or you can see the opening by retracting that upper lip and cheek laterally. And when you will press the parotid gland, there can be expulsion of some secretions or pus. So that is one point. Then asymmetry of face. What does it mean? How will you inspect? How will you examine? This is a very important question. Again, I am telling, I am not keeping inspection, palpation apart, and we are discussing it in total. So what is the importance of asymmetry of face? Huh? Facial nerve involvement. Then what is the course of the facial nerve? Very rapidly, after exiting from the stylomastoid foramen, what is the course? Very short. Any one of you? No, before that, it passes through the tympanomastoid groove. It passes through the apex of the tympanomastoid groove. It comes little below laterally and anterior. It passes through the just above the superior border of the posterior belly of digastric. Then it enters the substance of the parotid and divides into two main trunks. One is the superior and you know the muscle. So if there is asymmetry or nasolabial fold there is obliteration of the nasolabial fold, or the patient cannot close his or her eye. So that is the asymmetry. Difficulty in closing the eye, same difficulty in chewing food. That is involvement of the temporomandibular joint or affection of the muscles of mastication like masseter or medial pterygoid. Now drooling of saliva, the same point. It is not due to excessive formation of the saliva. There might be some problem in the swallowing or neuromotor affection. That is the same thing. Any other swelling in the neck. These are all negative points, but you will have to take into account and understand what will we ask about this history. So any other swelling in the leg, any lymphadenopathy, etc., loss of appetite and weight, you know. Why we will ask for? Yes. Next slide.
Didi, regarding past history, GS Koro?
Uh,
Put the question over there.
what is more important for the past history of the patient? What type of any past history? Pardon? Occupation.
Yes, number one, autoimmune disease. Actually, we are talking about parotid swelling. So, what could be the relevant past history in this particular case? One answer has come.
Autoimmune.
Autoimmune disease. Anything else? Yes, very good. Mumps is there. That can lead to
Yes.
chronic fibrotic changes in the gland and a persistent swelling in the gland.
Other disease?
Anything else?
Any name of the disease, autoimmune disease you are referring to? That is syndrome. Disease is Mikulicz disease. When Mikulicz disease is associated with polyarthritis and uveitis, it is called Jogren syndrome. So Jogren syndrome is affection of multiple salivary gland with lacrimal gland. That is your Mikulicz disease. And when it is associated with polyarthritis and uveitis, then it is a syndrome.
No.
So no personal history, nothing relevant here, except okay.
Skip kore jao.
General examination. Now inspection. I will ask you both the inspection and palpation. We will discuss how will you palpate the parotid. How will you palpate the parotid? তাড়াতাড়ি বলো, একজনকে ওঠো বলো।
These are the pictures. You can have some guideline from here. Huh?
How will you palpate the parotid? So superficial lobe and deep lobe. If you take it separately, then superficial lobe, how will palpate the superficial lobe? By telling the patient to clench his teeth and then moving the parotid. It will not go beyond zygomatic arch. And how will palpate the deep lobe? By manual palpation. How? One finger behind that ramus of the mandible and other finger in front of the tonsil, and you will palpate. Okay, so when it will be enlarged, it is palpable. Okay, now
Examination.
Now the position and extent. What is the extent of the disease? Now what do you mean by shape, size? These are the all examination for the swelling. So what is the shape? It has to be, if it is a benign lesion, although pleomorphic adenoma is lobulated, but it is generally smooth surface, and there will be
Directly chole jao. Examination of the facial nerve.
now you tell me how will you examine the facial nerve? Before going into further detail, how will you examine the facial nerve? See, what are the motor branches of the facial nerve to our body?
এটা একটু ছোট
Rapid.
করে দে তো।
So, the motor branches to the muscles of facial expression. What are those muscles? These are the frontalis, orbicularis oculi, buccinator, and platysma. Orbicularis oris. So it is oculi, it is oris. Frontalis, how will you examine the frontalis? By telling the patient to frown his or her brows. Okay. Then to close patient's eyes and you will try to open it. If it is not open, then it's normal. Then buccinator, you will tell the patient to puff, puff, yes. And you will press the both cheeks. If air is not coming out, again it's normal. Then how will you orbicularis oris? By whistling or blowing air. Okay. And then platysma by clenching the. Okay, so these are the muscles, and also it has motor supply to anterior 2/3 of the tongue. So these are the motor supply, and so these we have already discussed. And next,
Examination for cervical lymph nodes and temporomandibular joint.
okay. Now এর পরেরটা আগেরটা দিন হয়ে গেছে আমাদের আচ্ছা। Now for examination of lymph node, why will you examine the lymph node? Pardon? Neck nodes. I am talking about the neck nodes.
Cannot palpate the intraparotid lymph nodes. It's not possible. So whether it the mass is a malignant one, it may have some sort of metastasis in the neck. So what are the most likely areas of metastasis from the parotid?
Pardon? Level 2?
Level 2, level 3, is it? So level 2 I can take 3 or else 1B. So it's level 2 and 5, 2B and 5. Posterior
Okay,
triangle
just
and level
remember
2B.
this. Okay. And these are the signs of malignancy. Now next slide. Now regarding why that suppose this is the case of pleomorphic adenoma we are discussing. Now tell me why the pleomorphic adenomas are called the mixed tumors. What is mixed tumors? What do you mean by mixed tumors? So it can have both the mucinous material and also collagenous or cartilaginous material.
So just to
when-
interrupt the discussion that right now we are having our AOI president, Dr. Doipan Mukherjee within us. So a great round of applause for him, and he is organizing the entire event. Thank you, Doipanda. So back to the discussion.
Thank you. I'm sitting, I'm giving you the lecture. This is not the lecture. I have taken exam for last 30 years and MS exam for last 20 years. My main point is, we have got one long case, which is the maximum part we have to take 1.5 hours to 2 hours for long case, and 2 short case. This 2 short case means you have to give only the diagnosis, not to write the history, nothing to write, only the diagnosis of the thing. We usually give short case, as for example, if you have an ear case as a long case, we usually give nose or head and neck case as a short case. So 2 short case, 1 long case. And very important of this is parotid and submandibular, we seldomly give because it is falls in the domain of the head and neck region. For the head and neck region, we usually give thyroid, we usually give this thyroglossal cyst like this. But submandibular and parotid is also given, but seldom. So Ruma has given a beautiful narration, and Debu is there, and Viman is there. Haldia is giving a beautiful narration. We 4 have done it, and he has narrated the whole episode here. So, for the case summary, first of all, just like a parotid swelling, what Ruma has told you, they will tell you, what is this? This is a parotid swelling. What is the parotid? Where is the parotid region? You have to describe the parotid region. What is the importance of the parotid swelling? The group between the angle of the mandible and the mastoid tip will be obliterated. So, where it goes in front and behind, obliterating the group between the angle of the mandible and the ramen. That is the parotid. So, she has given a very good narration. So, parotid and submandibular are seldomly given, but you should know it, because if we don't have any cases, we have to give parotid and the submandibular gland. But these are always a short case, not a long case. So you should be knowing the inspection, how do you inspect it, how when the operation, how can you identify the facial knife, but trigger point, what are the other points you knew, how will you palpate the deep lobe of the parotid gland? These are the common questions that have been asked. So I will now, my younger brother and sisters are there, they will give you narration, and I wish you all the best. All association under Doipan is trying hard so that all you pass the exam very nicely, and we are always there. For the practical, I am telling you repeatedly, don't worry about the practical, because you have been working for 3 years in your institution, and the senior professor who is working under whom you are working, they know whether you are working nicely or doing thing or not. So for practical there is no problem. Problem lies in the theoretical. Theoretical is not being seen by the teachers who are taking the exam. It has been mixed, and through the computer we have to see in the examination. So be prepared yourself, parotid, submandibular, everything. You prepared for the theory is very, very, very important. So theory is the first domain part, and last secondly
এখানে
is
jump
the
করে
practical part. Thank you very much for coming all the way and I wish all the best. Thank you very much.
Thank you, sir.
So, after completing the inspection, I mean history taking and examination part, here is the case summary. This is the case summary. All you have seen on examination, swelling of.
So without wasting, sir, without wasting into the case summary, just ask them that
What is your
so far we have discussed what will be your provisional or
Provisional
working diagnosis. Again the last bench. Red shirt, Dhana.
Sir, we will first look for the positive findings in the inspection as well as palpation. So according to that, this might be a case of parotid swelling, which is benign in nature, most likely pleomorphic adenoma.
Points in favor of your diagnosis. Points in your favor of your
Gradually progressing in size since 4 years. No signs of complications.
complication do you expect?
Nerve involvement, facial asymmetry.
And one is the nerve involvement, that is the facial nerve involvement. Second, sudden increase in size, yes or no?
Rapidly growth is not.
Or fixing of the mass to the underlying masseter muscle or involvement of the skin. So these are the feature and also other investigation will corroborate the findings. Okay, so it is a benign lesion of larynx, benign lesion of parotid, probably pleomorphic salivary adenoma. Now comes the investigation. What investigation will you do in this case?
USG,
From the beginning to end, it is not suddenly.
USG
Ultrasonography, why?
to see if there is any presence of stone inside the
Stone.
or the extent of the mass.
So USG is the best investigation when the lesion is small and it is not involving the deep lobe, because in many cases the ultrasonography may miss the deep lobe enlargement. So there we will have to choose some other investigation. And also ultrasound. FNAC, it should be generally, if possible, it should be ultrasound guided FNAC.
USG guided
because,
FNAC.
Yes, USG guided FNAC because of many false negative or many inconclusive results. So whenever possible, it should be ultrasound guided FNAC. Now the role of further imaging,
Just a bit. Now just tell me how FNAC helps in this particular case. Why we are advising FNAC in this particular case? Number one. No, first we can have an idea that whether it is a neoplasm or not. Yes. That is the main purpose of performing FNAC. What could be the other findings? Chronic hyoidinitis, hyoidinosis, lymphoma like this, but main purpose of FNAC is to
give an idea whether it's neoplastic or not.
then next investigation.
We can go for a contrast and CT scan of neck of the region.
Suppose you have both investigation facility, one is the MRI and one is the CT scan, which one will you choose?
Well, in that case, I would choose an MRI.
Why?
Because it is a soft tissue structure.
Soft tissue structure, what will the MRI will do or tell about?
Any intraparotid
Neural elevation and lymphovascular injury.
PNI, LVR are the histopathological features that cannot be picked up in MR.
It is, she is right, you are right, it will tell more about the soft tissue delineation. That means ki you can differentiate between the normal parotid tissue and the lesion. So that is one. Second,
The status of the
facial nerve. Status of the facial nerve. Yes, very good. Third, when the lesion is too big, ultrasound is not sufficient to do, we will do MRI when the deep lobe is involved. Another, when we are suspicious of malignancy. Okay, so these are the points we will go for MRI. CCT or CT is not mandatory in cases. MRI will do. Next one is the true cut biopsy. What is the role of true cut biopsy? Will you go for it or you will not go for it? True cut biopsy. What does it mean and what?
Ma'am, if FNAC shows inconclusive results, then we can go for true cut biopsy.
Maybe due to less tissue.
Less tissues,
Okay, and if you are not sure of the diagnosis or it is, then we will do true cut biopsy. It is also ultrasono guided or USG guided. Okay, but it has to have some kind of specific forceps, punch forceps. So that should be available. So next. কি বলছো?
Okay, any other investigations you suggest? Number 1, role of chest X-ray. Role of chest X-ray in a case of parotid swelling. Not in this particular case maybe, but in general role of chest X-ray in a case of parotid swelling. In case of okay, maybe, and anything else? In case of sarcoidosis and Sjogren's, we can get some lymphadenopathy and parenchymal infiltrations. Okay.
Very important point. Okay.
Yes, sir.
Then
Role of FDG, PET CT, I mean, any role? Anything else? These are the investigations we can go for. For hypermetabolic lymph nodes, that is the only indication in case of parotid swelling, we can go for this. Number 3, molecular biomarkers, any role?
again the autoimmune diseases will.
These are the things, extra things for you may mention actually. I mean HER2. HER2 is associated with, do you know what is HER2? Anyone? HER2. That's an protein, huh? Human epithelial cell growth receptor 2. That is a very good factor to identify on the cell surface in case of mucoepidermoid carcinoma and salivary duct carcinoma. We need these things for the newer generation, that is the targeted therapies of these two cancers, salivary duct carcinoma and the mucoepidermoid carcinoma. These are the things you can mention. Chest X-ray, PET CT, molecular biomarkers. I think cyalography has no role. Anyone? Cyalography. Okay, forget it.
So
Next, based on all these things,
based on all this feature, it is provisional diagnosis is pleomorphic salivary adenoma. Okay. Now, how will you manage the case?
Devu, now it is your part.
It's a superficial parotidectomy.
Superficial parotidectomy. So then, what should be the position of the patient and what should be the incision that you will give? That
So
will make.
modified
Sorry.
grades, position should be supine and turn the head to the opposite side of the swelling. And
Before going into the detail of the surgery, I will add one point. If there is a very small 2 to 3 centimeter lesion in the parotid and the patient will tell ki Dr. Babu, if we don't do it, what will happen? So how will you counsel the patient?
there will be risk of spread of the cancer.
Whatever.
Spread, what is the incidence of the spread or what is the chances of pleomorphic salivary adenoma being malignant? So, okay, there is a benign lesion. So, first of all, it can get infected. There can be abscess formation or cystic degeneration or change into the malignancy. So, these are the things you can counsel and after that the patient will agree, I think. Now, next is...
So then one again question is that prior embarking into the surgery, what are the consent? What consent you must give prior parotid surgery?
Facial nerve palsy.
So what you will tell the patients? The facial nerve will go after the surgery. So no patient will give you the consent for operation. So how the way how you
There
should.
can be chance that after post surgery
So I
there
think
may be a
the
paresis.
language you should explain that you will be unable to close your eyes and your mouth movement
will
on that
be
side will be
deviated to other
less.
side.
So in that way you can avoid the language that your nerve get damaged.
You
So
have
the
to
next
explain
question.
to the patient what will
Yes,
happen
yeah.
if it's not possible.
So the proper informed consent of the
Consent
facial
is
nerve injury
important.
should be taken and should be signed by the doctor and the relative of the patient or patient. Rajiv tell me that I have only 8 minutes time. So next. So what should be the incision? The name of the incision.
Modified Blair's incision.
So what modification has been done by Blair?
It is starting from in front of the tragus, then going down.
Is it in front of the tragus or superior?
Superior to
Okay.
the tragus.
Then it come
may
downwards?
Come downwards, then surrounding the ear lobule. If we go more beyond the ear lobule, then it may cause necrosis, flap necrosis. Then we will not go more beyond.
Very good.
Then I
and
will
then we descend downwards. So
descend
in spite
downwards
of going deep,
along the skin crease and towards the upper border of greater corner of hyoid.
why she is telling that the greater corner of the hyoid, is there any particular structure that is important for us to make that incision is the marginal mandibular. So
Yes.
so we have made the incision. Now in what plane the flap should be elevated?
So it should be elevated in the subplatysmal plane.
Yes, that is the subplatysmal plane. When it ascends upwards, that is the smash layer.
Yeah.
So what is the smash? The full form of smash is?
Submuscular, I want to say this.
Okay, so then you have elevated the flap in the smash layer. So if the facial nerve is the Arjuna of the parotid nerve surgery, the Karna is the posterior division of the great auricular. It must be preserved as well. How should you identify the great auricular? What is the landmark? So it's the mastoid tip and the angle of the mandible. So midway in between these landmarks, you can identify the great auricular, preserve the posterior division, sacrifice the anterior division. Next. So you have identified you have elevated the flap, identified the great auricular, preserved the posterior division. Now, what are the landmarks you will look for?
We will check for the facial nerve.
Yes, so I will check for the facial nerve, but I will not go directly into the facial nerve. There are some landmarks that will help me to find the nerve. What are those?
Trager pointer and the posterior
Tragal
belly
pointer,
of,
number one. That is an inconsistent landmark.
and the tympanomastoid suture line.
Right.
And posterior belly of digastric artery.
Yes.
And
So these are mainly the three landmarks.
styloid process.
So what should be the location of the facial nerve in relation to these landmarks? First tell me.
In relation to tragal pointer, it will be 1 to 1.5 centimeters deep.
Inferomedial, very good. Then
And then as for tympanomastoid, it will be 6 to 8 mm deep.
Okay.
Tympanomastoid suture.
And then in relation to the superior belly, posterior belly of the digastric,
It will be posterior to the posterior.
it will be superior to the
Sorry,
superior to that. Now the question is, you follow all the landmarks, but you didn't get the nerve. What will do? Will you still digging deep to find the nerve? Or what you should do? You follow the standard protocol, elevated the flap.
Will use microscope.
Yes, you will microscope. You didn't get the nerve. Then
use the nerve monitor.
Yes, the use of nerve monitor comes into action. If you have then use it. Other way is, if you don't have the nerve monitor, it is the retrograde dissection of the facial nerve that sometimes helps to trace the nerve from its periphery to the trunk. Okay, so now you have identified the nerve. Next.
So 1 minute actually, what is the difference between nerve monitor and nerve stimulator? There are two terms. One is nerve monitor, another one is nerve stimulator. In the market, a nerve monitor cost around 15 to 25 lakhs, and a nerve stimulator cost only 35,000 rupees. It is always present with the anesthetist. For that, what was written in the part draping? Draping should keep the angle of mouth open, and the anesthesia should be without any muscle relaxant. During the surgery, if you suspect a structure to be a facial nerve, you just give some galvanic current to that nerve, and you will see the twitching of the angle of mouth. We are doing it routinely at our institute. It's a very good cost effective way, that is the nerve stimulator. It is of great value actually. You can see it always. Okay, Devu.
So now you have identified the nerve, traces the branches, remove the tumor. What after that? You remove the tumor.
So then, like, we need to check for the branches, like the artery, whether we encounter.
So tell me regarding the artery. So what is the relation of the retromandibular vein, facial nerve, and the external carotid artery? What is the usual relation? There are variations in that, but the common relation is superficial to deep.
So superficial temporal vein along with the maxillary vein will
First
call
lies
the
the
vein.
facial nerve.
Yeah.
Then lies the retromandibular vein, and then the external carotid artery. This is the usual relation.
Yeah.
So we removed the tumor, identified the branches. After that, what is left? After closing,
one question.
Before closing.
One question. What are the chances of recurrence after parotid surgery? Superficial parotidectomy tumi kore diyecho, patient has gone home. What are the chances of recurrence and why? Anyone?
They could be seeding beyond the capsule that is covering the parotid tumor. Usually if we do not remove it along with the capsule, there is a chances that it will be seeding.
So yeah, there is when there is some breakage of the capsule and spillage of the tumor tissue. So it can recur, but the incidence is very less, and it is over 10 years almost.
So to avoid the recurrence, you need to remove a comprehensive cup of tissue around the tumor.
Yes.
In spite of enucleating the tumor, you should remove a comprehensive cup of tissue, assuming that the pseudopods are into that tissue.
Yes.
So after removing the tumor, you should place a drain and then come out. So next slide. Skip. So these are the total conservative parotidectomy. You should preserve the branches when you find the tumor is lying deep to the branches. Next slide, sir. Next slide. So these are some of the complications of the facial nerve surgery. This is a radical parotidectomy done in a case of mucoepidermoid CA. The most common branch that is injured after superficial parotidectomy is why? There is anyone, anyone. It is very superficial, it is very long, it is very slender, and it is a long course. So these are the reasons for this is getting injured in most of the time. Next slide. So these are the cases of, suppose you are having marginal mandibular palsy. Permanent marginal mandibular palsy, the patient is not improving. How will you manage that case? So this is, I will tell you, so this is another common complications, that is the salivary fistula that most commonly occurs in the posterior part of the incision that blows out, and the patient is having a persistent discharge from that area, particularly during the time of chewing. So how do you manage that? So how to manage the marginal mandibular palsy? Sectioning of the DLI, depressor labii inferioris of the opposite side. So you can cut intraorally, this is an intraoral approach, you can cut the fibers of the DLI so that there is bilateral symmetry is maintained, and prior cutting those fibers you can check it whether it will act properly or not by infiltrating 2% xylocaine adrenaline infiltration and paralyzing the muscle to see that the bilateral symmetry, whether the bilateral symmetry has been maintained or not. So parotid fistula is managed by, it's a very difficult complication, but in most of the time it is managed by conservative management, regular dressing. Even if it is not improving, it can be managed by, flap is a bit morbid option, you can try the hypertonic saline injection, 3% NaCl injection that acts as a sclerosant. Next, so this is another common complications that I think most of you have seen in your tenure, that is the flap necrosis. That is in most of the cases resolved by itself by the secondary healing. And this is the most common complication. What is this? And what is the name of the test? Yes, so everybody knows everything. So it's a starch iodine test. Next. What is this? This is also a complications. It can be managed by simply by aspiration and by tight dressings. Next. Sacrificing. So these are the complications. I think we have covered most of the topics. I will give you all the rest of the question, answer and keys in your group, and for the sake of time. Okay, so the question is, what is adequate parotidectomy, the newer nomenclatures are the adequate parotidectomy and resection of the deep lobe of the parotid tumor. So will someone like to answer the question? What is adequate parotidectomy, please?
What a parotid submandibular is there.
Sir, adequate parotidectomy means superficial to superficial parotidectomy. When we take some part of the superficial lobe and facial nerve also intact, and in deep. No, sir. Only superficial part of superficial lobe. That is superficial to superficial parotidectomy.
Anybody want to comment on this? That is an extra. That is not adequate parotidectomy. In any sort of parotidectomy, you need to identify the nerve. Adequate parotidectomy is that you need to identify the tumor. The tumor, most of the tumor lies in a specific zone of a parotid. Either it lies in the tail of the parotid, either it is distributed in the temporozygomatic distribution or cervicofacial distribution. So the adequate parotidectomy is identify that segment of the nerve over which the tumor lies, and instead of searching for all the branches, you just dissect the branches that is crossing the tumor and remove the tumor. That is the adequate parotidectomy. And the next question is the resection of the deep lobe of the tumor. That is also very important. Anyone want to answer?
Sir, when lipoma or any adenoma specific to the deep lobe only, not only the superficial lobe.
So how? What is that? What is the resection of the deep lobe? And how will you do that? So clinically and radiologically, you have seen that it's a deep lobe tumor. So what you will do? A benign tumor, as you have said, it's a lipoma, or suppose it's a lipoma or it's an ectopic salivary gland tumor. So then?
So only part of the deep lobe removed.
So deep lobe of here also you need to identify the facial nerve trunk. You need to lift the facial nerve trunk from the rest of the parotid tissue and create some space all around the parotid so that you can deliver the tumor. In that course, the maneuvers you need to do is, it may require or may not require, if the tumor is large, it may require, is the division of the stylohyoid ligament, division of the posterior belly of the digastric, and sometimes you need to divide the hyoglossus muscle as well. So by that way you need a proper space and remove the tumor. I don't know whether I have answered the question.
So deep lobe is a part of parapharyngeal space. So it forms the lateral wall of the. So when the deep lobe will be involved on opening the mouth, the pharynx will be shifted to the opposite side and shifting of the uvula. So that clinically.
One question, how will you avoid Fraze syndrome post-operative?
How can you prevent Fraze syndrome? So the answer is from the paroperative prevention is the elevation of the adequate thickness of the flap. The smash flap should be a proper thickness so that it can be prevented. And even if it gets thin, inadvertently you elevated the flap and found that it's a thin one. So then you can interpose something in between the facial nerve or the parotid remnant of the parotid gland and the fascia. By these two methods, I think the Fraze syndrome can be prevented. Sir, you want to?
Also take a flap from the sternomastoid to cover.
So this is for the scarcity of the time, we are not going into the submandibular gland. That will not be given you in your exam. So all the best for all of you.
Thank you. I would like to thank the moderator, Dr. Bidhan Roy.
কাগজ ওখান থেকে দেন টাইম রাখার জন্য উল্টো দিকে লিখবো টাইম কিপিং